to speaking with everyone. Okay, I'm just going to share my screen. Okay, can everyone see the slides okay?
We can see them perfect.
Okay, alrighty, so I'll just get started right away. And unfortunately, I can't see you while I'm presenting. So if anyone has a comment, please save it for the end. Otherwise, I won't be able to call upon you to comment. So, all right. So over the next 45 minutes or so, I'm going to do the following. I'll discuss with you the relationship between patient education, health literacy, and health equity. Then I'll introduce you to the Cancer Health Literacy Research Center at Princess Margaret. And then I'll share some examples of patient education research from our lab. And let's just begin. So I thought I'd start today with sharing a definition of patient education, which many of you, I'm sure, are already familiar with, but I thought it might be helpful to ensure we're on the same page. There are many benefits to patient education that have been demonstrated in the published literature, and these include less prescription abandonment due to understanding why the medication is crucial to recovery, more follow-through with treatment plans due to understanding of the disease. Patient education leads to better patient satisfaction with providers and their overall care. It is associated with an increase in compliance of treatment plans and can lead to an overall reduced cost for patients and the constrained health system. It can ease patient anxiety about treatment. It can prepare patients to care for themselves at home. It strengthens communications between patients and providers, and it nurtures trust, confidence, and satisfaction. Unfortunately, though, these outcomes are not easy to accomplish, and the literature shows that much patient education that is delivered verbally or through print or digital materials doesn't meet health literacy best practices, and as a result, they don't accomplish the desired results. Before we go further, we need to discuss because I don't have this in presenter mode. Let me see if I can fix this. I wanted the animations to work, but for some reason I don't have the ability to put it in that view. Okay, maybe this is better. Sorry about that. So before going further, we need to talk about health literacy and its importance to patient education and to patient education research. Health literacy underpins both of them. So first I'm going to share with you a definition of personal health literacy, and I'll give you a moment to read it. Personal health literacy is influenced by a person's education attainment, their income, their exposures, and it is largely informed by functional health literacy, which is the ability to read and write and use numbers. Although with health literacy, it is in the context of healthcare. And this means that the idea of being health literate was related to a person's ability to read and write and use numbers. And so that means that being able to improve a person's health literacy was relegated to the education sphere. And it meant that there was very little space for intervention within the healthcare system. And this definition of personal health literacy has been the only definition of health literacy up until very recently. I mean, multiple takes on that definition, but essentially very similar to that. But in 2012, there was a paradigm shift where health literacy used to be thought of as state attributed to a person's education and that kind of thing. But now it's seen as something that can be improved within the context of healthcare, which is very exciting. And this happened with the conceptualization of the health literate healthcare organization. And this conceptualization takes into account system complexity and the skills of healthcare providers. This paradigm shift has led to an increase in health literacy research, as hospitals now have the ability to intervene and strive to improve personal health literacy. And this is where patient education can play a big role, as well as healthcare provider communication and patient teaching competencies. The Agency for Healthcare Research and Practice articulated 10 attributes for health literate organizations. And these are meant to help guide healthcare organizations who wish to become health literate. And most of the attributes involve patient education. And I'll share a few that stand out to me. Designs easy to use materials, targets high risk areas, and communicates effectively. But really, almost all 10 of them intersect with patient education. So health literacy practices and competencies. These have been articulated very nicely by Cliff Coleman and Stan Hudson, who I know both Tamara and I know personally. They have published quite a lot on this topic, but health literacy practice are patient-centered protocols and strategies to minimize the negative consequences of low or limited health literacy. And within that is probably the one that's most common for all of us is plain language writing. And that's really language or communication that a patient can understand the first time they read it, or they hear it, or they see it. And then health literacy competencies are the knowledge, skills, and attitudes which health professionals need in order to address low health literacy. So in my time as provincial head of patient education at CCO, we conducted some evaluation research to assess the current state of patient education. And we found that across the 14 regional cancer centers, that the print patient education materials that were distributed by the cancer centers, so this would be both materials that are developed in-house and materials that were distributed from community organizations like Canadian Cancer Society, Leukemia Lymphoma Society, etc., didn't meet plain language writing best practices. And as you likely know, or you may know, the best practice for writing in plain language would be to target your writing at a grade 6 reading level. Most of the cancer centers scored at over a grade 10, although I have to say that Odette and Princess Margaret did much better than some of the other centers. So in the context of the 10 attributes of a health literate healthcare organization, this means that we have much work to do in the domain of designs easy to use materials. So there are many challenges to delivering or developing effective patient education. And outside of the healthcare context, adults normally elect to participate in learning because of some incentive, including an occupational skills training, career advancement, or pleasure like learning to surf or learning to knit. However, in the healthcare context, the learning agenda is established by healthcare providers who often do not have time or know how to communicate the most salient aspects of the learning agenda to motivate the adult learner, because they're concerned about the treatment plan and all of the other details that only they can sort out. This poses a significant challenge to learning because it's contrary to the fundamental principle of how adults learn. Patients do not elect to learn. They find themselves in a situation where they must learn. And furthermore, patients are not necessarily prepared or incented to receive the information that they are taught or told by their healthcare providers. They may not know why it's important and why it matters. So applying the principles of andragogy and other important learning theories in the healthcare setting is a significant challenge, not only because much of the fundamental principles of these theories are completely contravened, but also because those that apply learning in their work who need to apply this, healthcare providers often don't have the knowledge and training to do so, or the time required to acquire it. So with these challenges taken into account, it becomes more clear that there's much work needed to improve patient education and to reap its benefits. And this is really where patient education research needs to come in to help figure out how to do that, given all the constraints.
Janet, just to let you know, we're only seeing you still on slide 5.
On slide 5, does it say patient education challenges?
No, it's just still on health literacy definition. Sorry, I just thought I'd let you know because a couple.
Oh boy, geez, that's a long way back. Okay, can you see them better now?
We can see them. They just weren't advancing. So now we can. You're back to actually. Oh, now we can see the organizational one, 6. But yeah, you might want to just skip to. Sorry.
Okay.
The joy
oh goodness.
of Zoom. We're listening.
Yes.
Attentively, but it'd be great if you could just catch us up.
Yeah, thank you, Tamara. Thanks for letting me know. That's terrible. That was way too long to hear me blather on the same slide. Sorry, everybody. So we went through health literacy practices and competencies. We went through, this is the slide that was talking about the work we did at Cancer Care Ontario, and Kristen was part of that, and Tamara. Ontario. And then this is the last slide I was talking about when I was going through all the challenges of patient education and really using this as a springboard to say there is a significant need to learn how to basically mitigate all of these challenges in the context of healthcare to improve patient personal health literacy as well as to build up organizational health literacy skills. Okay, so what is patient education research? And the definition is there. It's focused on learning how to improve patient outcomes and experience through education. And it includes a number of different types of exploration. And I listed 3 of them here. So one type of study could be theoretical work to test models to determine the variables that influence engagement or enactment of health behaviors. We did a study a few years ago looking at the associations of health literacy and self-efficacy to chemotherapy self-management behaviors to see if, if you had low health literacy, but you were very confident, could that potentially mitigate the low health literacy, et cetera. So that's that type of work. Then there's work to identify learning needs and gaps in knowledge. So those would be things like learning needs assessments, gap analyses, literature reviews, and then testing interventions targeted to improve specific outcomes. And those types of interventions in the context of patient education research are usually educational interventions. And we have a couple to share with you today. Is this slide advancing now? Do you see the health literacy and health equity slide?
Yeah, we do.
Okay, great. So it looks like if I don't have it in presenter view, it forwards better. So we'll keep it that way. So health literacy is also linked to health equities. And there is increasing interest in promoting health literacy as an immediate strategy to reduce disparities and provide patient-centered care. Compared to those with adequate health literacy, persons with low health literacy are more likely to experience disparities in health and healthcare access, and have lower rates of receiving screening and preventative services. Patients with low health literacy also exhibit patterns of utilization of care reflecting a greater degree of unmet needs, such as excess emergency room visits and unnecessary hospitalizations. And that's true even when comorbid conditions and health insurance status are statistically held constant. So, my lab conducted a literature review to examine the impacts of low health literacy in cancer about a year ago or 2 years ago. And we found that low health literacy was associated with a number of outcomes, including less use of preventative health services, less likely to follow medication, to comply with medication instructions, and also reduced ability to communicate with healthcare providers, et cetera. This paper has been published. It's in the Annals of Cancer Epidemiology if you'd like to read it. Although I can see that the reference isn't here, so I can share that after if anyone is interested. The implications of these associations are significant both for patients and for the healthcare system. And we found individuals with low health literacy may present to the cancer system with more advanced stages of disease or lack the skills required to self-manage their illness, leading to higher mortality and morbidity and greater cost to the healthcare system. So there's much work to be done to help mitigate the effects of low health literacy in cancer. And now I'm excited to introduce you to the Cancer Health Literacy Research Center at Princess Margaret. So I founded the Cancer Health Literacy Research Center in 2017, and its goals are to empower patients and families to reduce health disparities, to build healthcare provider health literacy skills, and these include patient teaching competencies, toward more efficient use of health services and better health outcomes. Specifically, we conduct research to better understand the impact of health literacy, how it contributes to overall cancer self-management and health outcomes, and what the implications are for health systems. We develop and evaluate interventions that aim to improve cancer care through health literate approaches, and we foster a community of education researchers who are committed to transforming cancer care for the future. So this is a snapshot of some research productivity over the last couple of years. We surprisingly managed to remain fairly productive despite the pandemic. We had to switch gears and did a lot less recruitment and clinical research work and more lit reviews, but we were able to continue to get things done. We take in a number of students, both master's and PhD students, from schools of public health, particularly students who are working in degrees in health communication or epidemiology. We get a number of studies of students from IHPME at University of Toronto and library sciences, and a number of health professional students working on research placements too. You can see that our grant funding may be small for those of you who may be used to seeing clinical research dollar amounts for grants received, but education research is much less expensive to conduct. And so typically the size of grants available for us is a lot lower, but it's sufficient for what we need. And the awards and honors you see here are largely these 6, largely won by students presenting their work in research posters. So yeah, I think that's, well, I'll just mention one more thing. Our research is underscored by health literate care and the concept of the health literate organization. And we look at ways to improve patient health literacy through patient education implemented in clinical settings. Right now we have 17 active studies, but today I'm going to tell you about 5 of them, but 4 of them are interrelated. So I'm really telling you about one small study and then a bigger kind of cluster of studies. And the first one I'm going to tell you about is an RCT, a randomized control trial that is currently underway, that seeks to evaluate the efficacy of a self-care education program that we developed for cervical and endometrial cancer patients undergoing brachytherapy. And then I'll spend the bulk of my time talking about some caregiver research and support. So the first study I'll share is an example of an intervention study where we seek to determine whether the intervention, in this case an online self-care education program, can improve patient satisfaction with education and care, their quality of life post-brachytherapy, vaginal dilator compliance, and rates of vaginal stenosis. This work was funded by a University of Toronto Department of Radiation Oncology seed grant, with myself, Dr. Croak, and Dr. Giuliani as co-principal investigators. So I'll start with a little introduction of why this matters. Although brachytherapy is an effective treatment modality for gynecologic cancer, a significant proportion of patients develop late treatment-related vaginal toxicity, which negatively impacts their quality of life and limits recurrent disease detection by preventing adequate clinical exam during the post-treatment surveillance period. Consistent with the literature and the results of a study that we conducted a few years ago at Princess Margaret, where we, oops, I shouldn't switch yet, where we surveyed both patients and healthcare providers to ask them about their opinions of current education and vaginal toxicity management. They shared kind of unanimously that the training is inadequate. So both the patient training or education as well as the provider training and education. So we seek to implement and evaluate this new online brachytherapy discharge education course for patients. So the specific aims of this research that we're conducting is a randomized control trial design, and the overall impact of the program is going to be identified using outcome scores that we collect at 3 different time points. So all of the patients complete self-report questionnaires, e-learning modules that have videos embedded within a compliance diary. And then the endpoints of the study are completion of the e-learning modules, the compliance diary, self-reported questionnaires on rates of vaginal stenosis at 1 year post, and also a clinical endpoint of vaginal stenosis that the clinicians collect. So this is what the Brachy self-care education program looks like. And this is the video, which apparently I can't share because you can't hear my volume. So Antoinette, are you, or Tamara, are either of you able to share it?
So I can't get into it, Janet, because it's going to, it's pushing me through the Microsoft team, like to SharePoint, and I just tried to get into that account, it won't let me in. I don't know if Antoinette can.
Okay. Well, you know what I can do? I can show parts of the video. You'll miss a fair bit with the narration, but at least you can see what it looks like, and you can maybe get a bit of a sense of it. So this video itself, and then we can obviously the slides can be shared afterward, and you can see it. But what this video is meant to accomplish is to help the participants understand why it's important to use their dilator. In our study that we had conducted prior to developing this education intervention, we had learned from the patients as well as the healthcare providers that they're terribly embarrassed about using the vaginal dilator. The providers are embarrassed to talk about it. They don't know how to refer to it in a way that doesn't seem sexual. And the patients feel embarrassed because they feel that it's sexual as well. So we have made an effort to refer to the dilator as a medical device and to tie it back very clearly to a medical need. And so I'll show the video, and I think you can get the gist of it even without the sound. So this is when we're describing what vaginal stenosis is. And this is talking about scar tissue forming in the vagina after brachytherapy, and how the scarring can cause the sides of the vagina to become narrow and stiff. And this is where we say it can cause pain, discomfort, and make vaginal medical exams and sex hard and painful. So here we are saying why preventing vaginal stenosis is important. And here the narration is saying what you see on the screen. And this says, the most important thing you can do to reduce vaginal stenosis is to use a vaginal dilator to keep your vaginal canal widened and open. Then it says, the dilator is a smooth tube that goes into the vagina. It breaks down scar tissue and slowly stretches the walls of the vagina over time to reduce stenosis. This goes through when to start using it. And then it says if it is sore or your vagina feels swollen, wait a few days and then try again to set up the expectation. And it acknowledges it takes time to adjust using a dilator. And after a while, using the dilator will become routine. And it says, talk to a member of your cancer care team if you have any trouble. They're there to help you. And that is the end of that video. I'm sorry you couldn't hear it. I hope that my narration was okay. This video, I chose it because it nicely illustrates the importance of patient education materials to be accessible in terms of literacy and language. So all the terminology was very simple, and if anything was complicated, like vaginal stenosis, we explained it and showed what it was. It also shows the importance of tapping into the learner's motivation by clearly explaining why the education is important, and building in content designed to increase the learner's confidence that they can perform the needed actions. So I'm sorry that the video didn't work, but hopefully you got the gist of most of that. So far with the study, those that are in the that are completing the modules, those who are in the intervention arm in the randomized control study are completing the modules right through, and they're watching all of the videos. And although we don't yet know it's going to have an impact, we can see at least that they are completing the education. So hopefully that means that they're enjoying it and that it's engaging and helpful. So the study runs for another year, and hopefully we'll report back some positive results. Through the course of developing this content with the subject matter experts at Princess Margaret, we realized that many of the healthcare providers are using different terminology when addressing different elements of post-treatment education for brachytherapy. And in anticipation of this and rolling out this program as a standard of care, we're building a companion education module for the healthcare providers responsible for brachy education. And this was a request from the practice leader who has said that staff have shared that they would all like to be on the same page, and they are still expressing that they're uncomfortable providing brachy education, and having terminology like a medical device makes explaining the dilator less embarrassing for them, or it makes them feel less uncomfortable. So we are building this to help fill in some knowledge gaps and reduce discomfort with the requisite teaching. Okay, so now I'm on to the caregiver education program. So this is work that we've been doing over the past couple of years to learn about the needs of cancer caregivers, and so that we could build an education program, a health literate patient education program to help support caregivers. The people you see on this slide are the Princess Margaret Caregiver Advisory Group, and they're also co-investigators on the research studies. We have expertise across many disciplines engaged in this work, and we also have 5 caregivers on the team. Their names are listed at the bottom. They hadn't wanted their photos posted on our website, so I had assumed they probably wouldn't want their photos posted here, but they're happy for me to share their names and their insight and and support of this work has been critical. So there is, we have been conducting a series of 6 studies to learn about the needs of caregivers and existing education and support, as well as gaps in caregiver knowledge and how best to educate a population that is already feeling very overwhelmed. But today I'm going to tell you briefly about 4 of them. There's a little bit of background, and then there's about 3 slides per study. So that is my mom right there. She's just had total knee replacement surgery. And she's on this slide for a good reason, but I'll give you the background first and then talk about my mom. So informal caregivers are central members of the cancer care team, and they're important for delivering high quality care. Despite the central role that caregivers play, we know that they receive very little or no direct support or training. And despite this, caregiver responsibilities are continuing to increase. And we can see this with more treatments being delivered in the outpatient setting, see knee replacement surgery patient, decline in available healthcare resources, and a shortage of healthcare providers. And there are a number of organizations who are advocating for greater caregiver support and training programs. And certainly this background resonates with me. Last week was my turn to take care of my mom. My other sister took care of her immediately after surgery, and then I was a week later. And I can tell you that despite the enormous amount of patient education material I had received, it was contradictory. A lot of it it wasn't structured in a way that flowed in a chronological order, so it was a little difficult to get through it. But even with all of that information, I felt very overwhelmed and very worried that I would make a mistake that would end up harming my mother. But she is on the road to recovery now. She's 3 weeks in, and my third sister is taking care of her this week. But it really does make me think about equity. And we're very lucky that first we have a large family and we can take turns taking care of my mom, but also that we were actually able to do that we were able to take the time off work and get paid for it. So take vacation time in order to do it. And I think many people don't have this luxury. I believe that total knee replacements in the United States even are still, you are an inpatient for 2 to 3 weeks. And it's interesting that I know with our constrained system, and there are many benefits to it, of course, we really need to think about who is able to benefit from these treatments and what is the impact of a caregiver that has lower health literacy or less of an ability to navigate the complexity of the information provided. So the cost of caregiving is not equally felt among Canadians. Caregiver burden is disproportionately higher among certain segments of the population, and they're listed here. Elderly caregivers, certainly in my case, my father is 81 years old, and he is really not in a great position to take care of my mom, as well as Black and Hispanic caregivers, female caregivers, and those with lower socioeconomic status. So we did, as I'm sure you can recognize, caregivers need education and training, and increasingly education programs are being developed to support caregivers of patients with diseases like dementia and Alzheimer's. So we conducted a review of the literature to understand and summarize what was known about existing efforts to support caregivers of cancer patients in the extant literature. And specifically, we were interested in 4 things. The curriculum of these programs. So what was being taught, or what is being taught to caregivers? How are the programs delivered? Are they in person? Are they hybrid? Are they remote? What does participation entail? Is it, clicking through an e-learning module, or is it a 5-week course, or is it a 3-month course? How is the program ordered, or what is the context for it? And then importantly, who participates in these programs? So we took a look at all of these published studies, and we looked at who was participating. So what was the age of the caregivers? What were the genders represented among the participants? What was race? What was the income level, education, and that kind of thing? And our initial search yielded just about 35,000 articles, and thankfully it was narrowed down significantly once we removed duplicates, and we were left with summarizing 119 studies. This work was recently published in Patient Education and Counseling, and the reference is here if you would like to read it, but I'll share some of the highlights. A very small number of caregiver self-management programs were identified in the review. So 119 in total, and this was global. This was articles not just published in English. The vast majority of caregiver programs were focused on psychological well-being, And they did not holistically address the full spectrum of caregiver needs. Now, of course, the psychological needs are critical and very important, but there are a number of other things that actually could help to reduce the psychological burden, including education. And most of the existing programs required in-person attendance at a specific time and at a specific location. And this, of course, can limit access to caregivers who are living in rural areas or those with multiple care demands, young children at home or aging parents to take care of, or those with lower socioeconomic status maybe can't take time off work without losing a paycheck. So our review demonstrated a need for a comprehensive caregiver education program to address the full spectrum of caregiver needs. And there is a substantial body of evidence that shows the negative impacts of low health literacy on caregiver health. And this includes poor care recipient self-management behaviors, increased use of health services, and a number of others that you can read on this slide. This is particularly problematic because of the high prevalence of low health literacy in Canada, which is estimated to be between 60 and 80% of the population. Thus, the health literacy of caregivers needs to be considered when interventions are being developed for them. So the Cancer Health Literacy Research Centre has the expertise to develop health literate interventions, which are made to be universally acceptable to patients with low, moderate, or high health literacy. So the next study we did, diving into the needs of caregivers, was a qualitative study to assess their training needs. So we looked at the literature at what training programs existed, how they're offered. We looked at the literature to see what the training needs are as well, but we wanted to talk to patients at caregivers and patients at Princess Margaret to ensure that what we found in the literature was indeed consistent with our population.
Oh God, I didn't get to call them.
Did somebody mute?
Wendy? What did she say?
Can you please mute your volume?
For tomorrow is
Antoinette, maybe you can actually mute
I'm
everyone.
going to call her.
the 0 and 1.
All right.
Can't
Okay.
see actually who's.
Yeah.
Can you please mute everyone? Ensure you're on mute. Thank you. The troubles and travails of Zoom, I tell you. I should have come in person. So with this particular, sorry, I've kind of lost where
Hi, are they here now? Hi,
Antoinette, can you
hi,
mute?
we called for a stat clean and the patient is here and there was no one here. Just let me check that someone's come. Sounds there. Oh, they've come now. Okay. Thanks, Richard. Okay. Was that Thomas? Sorry, Thomas. Okay. Okay, then. Thanks a lot, you too. Bye-bye.
Okay, I can't compete with that. That sounds like it was very important, but here goes. So we received some grant funding.
Thank you. Yeah.
From the American Association for Cancer Education to conduct a qualitative study to assess the education needs of Princess Margaret caregivers. And we have found, and as I just mentioned, what we wanted to see is if what we found locally would align with what was published. And indeed, we did find that that's true. So we found that caregivers have a strong desire for information, and this is true even of seasoned caregivers. So we asked the caregivers and patients that we interviewed in this qualitative study for their thoughts about the idea of a Princess Margaret education program for caregivers, and there was really strong support for it. We asked them specifically what topics they wanted education and training on, and then we showed them a draft curriculum that the Caregiver Advisory Committee had put together in anticipation of what their needs might be. And again, there was really great synergy between them. And so very strong support for the program. So then we wanted to think, okay, so we've interviewed some caregivers, none of them were newcomers. We did try to have a maximal variation sample where we tried to find caregivers of different socioeconomic contexts, different racial backgrounds. We did have really good diversity in age and gender, but not much in the other areas. So then we wanted to do a literature review to look at what are the specific needs of newcomer caregivers, specifically with regard to cancer. And so the literature shows that newcomer status is a predictor of caregiver well-being and quality of life. Newcomers who also have limited language proficiency, meaning that their spoken language is discordant with the dominant language of their health system, experience challenges navigating the healthcare system and poorer health outcomes when compared with their language proficient counterparts. In addition, newcomers with lower socioeconomic status and limited language proficiency see faster deterioration in their health upon migration. So our team conducted a literature review. Again, literature reviews were a really good opportunity for us during the pandemic when there wasn't much recruitment being done. And what we wanted to find out were what are the needs of newcomer caregivers with limited language proficiency. And what became apparent to us in this review was that newcomer caregivers occupy a very unique space in the healthcare system. They liaise between healthcare providers, the patient that they are caring for, as well as family and the extended family of the patient, as well as interpreters. And language barriers further complicates all of these relationships. So this is just an image that shows the 4 major thematic categories that kind of came out of this review. But I'm only going to talk to you today about language discordant communication because we don't have a lot of time to go into all of this. So I have a few highlights to share with you. So the studies in this review showed that verbal communication between health providers, caregivers, and caregivers with limited English proficiency was difficult for both parties. And on the one hand, healthcare providers felt that the language barrier limited the quality and quantity of information that they shared with caregivers, and that the use of the interpreter led to uncertainty regarding the accuracy and the completeness of the information transfer. So the healthcare providers are left feeling a little uneasy, even though they've trimmed down what they're providing to the interpreter to share. Healthcare providers also named several concerns regarding the use of professional interpreters specifically, including concerns about the accuracy of the interpretation, the challenge of building rapport with the patient and the caregiver and navigating that triadic relationship, and needing to simplify information to facilitate the interpretation process. In one study, oncologists reported having to oversimplify consultations due to challenges describing kind of theoretical or abstract concepts with the patient and caregiver through the interpreter. Several studies cited the importance of healthcare providers to provide information in a clear and simple way so that it can facilitate the information transfer from the professional interpreter to the patient or the caregiver. And in many instances, caregivers were required to interpret for the patient. And I'm sure this happens at Odette too. It certainly happens at Princess Margaret, even though we try to avoid it. When the caregiver is interpreting, they report challenges with taking on this role, such as difficulty interpreting the complex medical terminology and feeling ill-equipped to communicate bad news directly to the patient, while being able also to provide that emotional support. So the newcomer caregivers with limited language proficiency have significant challenges outside of what naturalized caregivers have to face. So we used what we used from the literature reviews, the interviews, and the consultation from experts in the field to build the caregiver education program. And this is sort of what it looks like. But as I mentioned earlier, the burden of caregiving is not equal, with certain populations of caregivers experiencing heavier burdens. As such, we designed this program to be virtual and asynchronous. So you can take it anytime you like, on your own time. There's no constraints in terms of temporality. And the digital format addresses limitations of in-person teaching or didactic programs, such as limited reach and engagement, time constraints, and out-of-pocket costs for those who otherwise may have had to take time off work and then probably not come. So in addition, the program was developed to be digitally health literate, to make it simple to navigate, and all of the materials within it adhere to health literacy best practices. So they're written in plain language, they're actionable, and they are understandable. This is what the program looks like when you log in, although there's some videos up front to make it more appealing. The curricula covers 6 domains of information need, including medical needs, so about cancer, what is it, how you might get it, so some of the genetic components of it. The physical, so it talks about side effect management, social, emotional, practical, and spiritual. And this program includes over 1,000 education assets, including videos, animations, e-learning modules, links to websites, and printable materials. But when you look at it, you can't tell there's so much in it. It's very deliberately designed not to overwhelm the already overwhelmed caregiver. And we have been conducting usability testing along with an evaluation of this project. And the caregivers really are very happy with the interface and the accessibility of it. So I don't have much more to tell you, except that there are some special elements that we added to support newcomers within the program. One is we built a number of communication modules that are specific to the needs that were identified in the literature review. So these were modules about communicating with a person with cancer, communicating with healthcare providers, communicating through an interpreter, communicating with family and friends, and then a module on communicating with children. And although those are useful for everyone, they were specifically made based on what we learned from the newcomer caregiver lit review. We also developed audio files that reside with any of the print materials in the program. And those are simply small files that the individual can click on to listen to if they have lower reading skills. And those with limited English proficiency hopefully will benefit from those audio files. We do have translated materials within the program whenever they were available, but we did not have a translation budget to translate the entire program, but we do hope to do that eventually. And there's also a section in here for connecting caregivers to community supports, and in particular, excellent supports for newcomer caregivers. So the last study of the 4 caregiver studies is a phase 2 evaluation. And a phase 2 evaluation is usually to assess feasibility and acceptability and maybe preliminary efficacy of an intervention. And in this case, that is what we are doing. So we'd like to provide preliminary data on the feasibility, acceptability, and efficacy of this asynchronous education program. Our primary outcome measure that we're looking at is decreasing caregiver burden, and that is being measured using the caregiver burden scale. And then we have some secondary aims, which are to provide preliminary data on the influence of the intervention on participant satisfaction and caregiving competency. So this study is underway right now, and we are almost halfway through recruitment. This is the, I think, second last slide in my deck. As we have seen, health literate patient education interventions hold promise for removing several barriers to patient learning. Health literate patient ed interventions can address health literacy related barriers by being written in plain language and by following clear design guidelines. The adult learner can be engaged and motivated to learn by establishing the relevance of the learning up front, which I wish you could have seen better in that brachytherapy video I showed you. Hopefully my narration allowed you to see that, and can take some of the burden off of time-constrained healthcare professionals, and also reducing the need to be extremely proficient in plain language education. And so just in conclusion, health literacy skills we know are the strongest predictor of health status, and patient education research are means through which health literacy disparities can be addressed. And health literate approaches to care benefits everyone. It benefits patients, it benefits caregivers, and it benefits already very heavily burdened and overwhelmed healthcare providers. So it really is a great approach. And on that last note, I thank you for your attention, and we'll hand things back over to Tamara, perhaps.
Thanks, Janet. That was excellent.